Welcome and thanks to all of you for joining us today. My name is Rohit Mehra, and I'm honored to open this GUPS Virtual Education Series event session organized by our GUPS Education Committee. Like you may know, GUPS was founded with a clear mission to enhance patient care through excellence in education, research, and implementation of best practices. We are here to learn and share in the collective progress all of us are making towards advancement in the field of urologic pathology. Today's session itself focuses on a critical and evolving topic and is entitled Difficult Areas in Testicular and Paratesticular Pathology. We are privileged to have three outstanding genitourinary colleagues speak at today's event: Dr. Ezra Baraban, Dr. Andy Acosta, and Dr. Chris Przybycin. This session is being moderated by Dr. Liwei Jia from UT Southwestern Medical Center and Dr. Jeff Chen from MSKCC, who are members of our GUPS Education Committee. We encourage all the audience members and attendees to please submit your questions within the Zoom Q&A tab throughout the session. Our speakers will address them at the end of the three presentations. Without further ado, I'm requesting Jeff to introduce our first speaker, Dr. Ezra Baraban. Over to you, Jeff.
Thank you, Rohit. So our first speaker today is Dr. Ezra Baraban. He's an assistant professor at pathology at Johns Hopkins Hospital, specializing in genitourinary pathology and bone and soft tissue pathology. He received his MD from Yale University School of Medicine and completed residency in anatomic and clinical pathology at the Hospital of the University of Pennsylvania, followed by fellowships in surgical and urologic pathology at Johns Hopkins. He is actively involved in teaching pathology residents and fellows and has received several awards for excellence in both research and education. Dr. Baraban will be speaking on the topic of testicular neuroendocrine tumors from tumor biology to clinical diagnosis. Dr. Baraban.
Thank you so much for the opportunity and for that introduction. And I'll just go ahead and share my screen. And we'll go ahead and get started. Okay, so thank everybody for attending. And today we're going to go ahead and review issues related to testicular neuroendocrine tumors. So I've divided the talk into three sections. In the first part, we will start with an overview of neuroendocrine neoplasia. In the second part, we will compare features of neuroendocrine tumors across the GU tract from the top to the bottom. And then we'll go in detail into the differential diagnosis and some mimickers of testicular neuroendocrine tumors. So let's start with an overview of neuroendocrine neoplasia. So before delving specifically into testicular neuroendocrine tumors, let's put them into context of neuroendocrine neoplasia as a whole, which has three major branches. The first major branch consists of paragangliomas / pheochromocytoma, which arise from autonomic ganglionic tissue. The second branch are the well-differentiated neuroendocrine tumors, or NETs, and these are formerly known as carcinoid tumors, which most frequently arise from the GI tract or its appendages. Lastly, neuroendocrine carcinomas are completely distinct from the first two categories and most commonly arise as transdifferentiation from underlying glandular or squamous neoplasms, which are often not sampled because the neuroendocrine carcinoma component is so aggressive and so proliferative that these lesions will overgrow the other components. Patients often present with metastatic disease, and these tumors may not be resected. So paragangliomas have nested or sheet-like architecture and often have granular purplish cytoplasm, as illustrated on the upper left, like the benign paraganglial tissue from which they arise, shown on the upper right, as well as neuroblastomas. Paragangliomas express synaptophysin, chromogranin, and the transcription factors GATA3 and FOX2b. They frequently occur in the setting of hereditary predisposition syndromes, and they may be the sentinel diagnosis for a syndrome such as succinate dehydrogenase deficiency, which we can screen for using IHC for SDHP, which is shown on the bottom left, in a patient who did turn out to have germline SDH deficiency. They occur in the paramidline along the sympathetic chain, all the way from the inner ear down to the pelvis. Now, in the GU tract, we encounter these most often in the adrenal gland or in the bladder, where particularly when we encounter them in cauterized transurethral resection specimens, they mimic invasive high-grade urothelial carcinoma, a pitfall which is exacerbated if we rely entirely on GATA3 to support urothelial origin. And this is readily avoided with an IHC panel, which includes neuroendocrine markers, and most importantly, a pan-keratin. So on the bottom right is the prototypical nightmarish case of a cauterized bladder paraganglioma, which could easily be mistaken for high-grade urothelial carcinoma, but easy to distinguish with the proper immunohistochemical panel. The second major family are the well-differentiated neuroendocrine tumors. These are epithelial-derived tumors that typically arise in association with the GI tract or its embryonic derivatives, like the lung or the pancreas. As shown in the upper left, they frequently have nested or trabecular architecture. They reliably express pan-keratins, as shown on the upper right. They typically have a very low Ki-67 proliferation index, as shown on the lower left, such that even patients with stage 4 disease can live for years or even decades. They consistently express somatostatin receptor, as shown in the bottom right, which is the basis for staging with dotatate PET imaging and also for delivery of intravenous targeted radiotherapy. Adenocarcinomas, particularly of breast or prostate origin, frequently express neuroendocrine markers by IHC and can strikingly mimic neuroendocrine tumors on H&E. So when dealing with a potential neuroendocrine tumor of unclear primary origin, depending on the patient's sex, NKX3.1 or GATA3 stains are very helpful for avoiding this pitfall. So the last branch are the neuroendocrine carcinomas, which are biologically distinct from NETs and frequently arise through transformation from pre-existing adeno or squamous cell carcinomas, which is reflected in their genetics, which generally parallel the mutations seen in corresponding non-neuroendocrine carcinomas of a given organ, with neuroendocrine carcinomas of the prostate, for example, frequently harboring ERG fusions, and bladder neuroendocrine carcinomas often harboring TERT promoter mutations. So histologically, these tumors are overtly high-grade malignancies with obvious mitotic activity and necrosis, with classic small cell morphology on the upper left. TTF1 can be expressed regardless of the site of origin, as we see on the upper right. RB mutations are a recurrent feature, and RB loss by IHC, as shown in the lower right, can help to support the diagnosis as part of an immunohistochemical panel, and Ki-67 often approaches 100%, as shown on the lower left. And from an immunohistochemical standpoint, neuroendocrine carcinomas tend not to express diffuse P40 or NKX3.1, and also keep in the back of our mind that rhabdomyosarcoma and Ewing sarcoma are notorious for expressing neuroendocrine markers. So Desmin or NKX2.2 are reasonable ways to screen for these, particularly if we're not 100% sure we're dealing with an epithelial lesion. Rarely with fortuitous sampling, we can encounter a neuroendocrine carcinoma in the act of transformation from an underlying non-neuroendocrine carcinoma, as in this example of urothelial carcinoma in situ, outlined in red, directly in the act of transforming to an invasive small cell carcinoma of the bladder. So with that context established, let's now focus on well-differentiated neuroendocrine tumors for the remainder of the talk, which we'll review from the top to the bottom of the GU tract. So on to the second section. So even within the GU tract, where neuroendocrine tumors are much less common than they are in the GI tract, there's substantial diversity among neuroendocrine tumors occurring in different GU organs. So I want to draw some attention to these contrasting and distinctive features of neuroendocrine tumors that arise in the kidney, bladder, prostate, and testis. And testicular neuroendocrine tumors are unique in that they're germ cell derived, which we'll go into much more detail in a moment. So starting from the top of the GU tract, renal neuroendocrine tumors typically have an intricate maze-like anastomosing architecture at low power, as seen on the left. Their genetics are not very well characterized because they're so rare, but interestingly, in a subset of cases, they're accompanied by adjacent cysts lined by intestinal type epithelium, suggesting that they may derive from displaced or metaplastic enteric epithelium. So on the bottom right is a low power image from a partial nephrectomy with a primary renal net enlarged in red just above, which was arising immediately adjacent to a cystic lesion, which was lined by intestinal type epithelium with goblet cells, outlined in blue in the upper right. So here's another similar case with a radical nephrectomy section showing non-neoplastic renal parenchyma on the upper left, outlined in black, and a well-differentiated neuroendocrine tumor outlined in red and magnified at the upper right, with an anastomosing architecture and rosette formation, again arising adjacent to a cystic lesion highlighted in blue at the bottom, which was lined by mucinous enteric type epithelium that was CDX2 positive. On the bottom right, we can see that synaptophysin is strongly positive in the neuroendocrine tumor and negative in the cystic component. And we presented these findings at the most recent USCAP, and we're working on completing our series for publication soon. Moving down to the bladder and to the urethra, where well-differentiated neuroendocrine tumors are extremely rare, but in contrast to renal nets, which show anastomosing architecture and are often aggressive clinically, these tumors typically show tubular morphology. They arise in association often with cystitis cystica, with or without intestinal metaplasia, and are usually very indolent clinically. So here's an example of a urethral neuroendocrine tumor with tubular architecture and overlying benign urothelium with cystitis cystica. The location and the tubular architecture can certainly cause diagnostic issues, and these tumors can definitely mimic prostatic adenocarcinoma, for example. The granular cytoplasm, often with polarized, basally distributed purplish neuroendocrine granules, as highlighted in the red, is a useful morphologic clue. And the basal distribution of neuroendocrine granules is highlighted nicely by a chromogranin stain on the upper right, which corresponds to the two-tone cytoplasm seen on H&E. If you're concerned about involvement by prostatic adenocarcinoma, pin 4 on the bottom right is a diagnostic pitfall because, of course, these lesions are not surrounded by basal cells. Lack of NKX 3.1 is the key to excluding prostatic adenocarcinoma. Here's one other example of a urethral neuroendocrine tumor with this tubular neoplasm directly undermining benign urothelium with cystitis cystica, and a chromogranin stain didn't just highlight the tumor cells, but also scattered individually dispersed neuroendocrine cells within the overlying urothelium on the upper right, which likely reflect derivation of this lesion from the overlying urothelium. Moving to the prostate, where neuroendocrine tumors are vanishingly rare, and most low-grade tumors with neuroendocrine differentiation are adenocarcinomas, with the most dramatic examples being the so-called Paneth-like variant of prostatic adenocarcinoma, which has striking red cytoplasmic granules. The main significance of this lesion is that while it architecturally mimics high-grade prostate cancer, a Gleason score should not be assigned, as this would overstate its aggressiveness, which is significantly less than conventional grade group 5 prostate cancer. And these are not only mimickers of neuroendocrine tumors, but also should not be mistaken for a true neuroendocrine carcinoma, as these are not highly proliferative lesions and are very distinct from small cell carcinoma. Occasionally, neuroendocrine cells can be seen admixed with or studded into prostate cancer, as outlined in red, and you can see these on H&E. And the clinical significance of these are not entirely clear. Again, the main issue is to avoid confusing this feature with a neuroendocrine carcinoma, recognize these lesions as prostatic adenocarcinomas rather than NETs or NECs, which can be a challenge, particularly when these lesions present as, for example, local extension into the rectum and could very well mimic a rectal adenocarcinoma or neuroendocrine tumor. And again, NKX 3.1 positivity is very useful for excluding these mimickers. So, having covered a whirlwind tour of neuroendocrine neoplasia and specific features of neuroendocrine tumors up and down the rest of the GU tract, we'll spend some time on primary testicular neuroendocrine tumors, which are rare but very interesting, as while these are phenotypically indistinguishable from neuroendocrine tumors of other sites, they're unique in that they're derived from germ cells. And again, at high magnification, they're indistinguishable from well-differentiated neuroendocrine tumors of GI tract origin, and that's likely because they arise from intestinal type tissue within underlying testicular teratomas. So although testicular neuroendocrine tumors themselves are extremely rare, they actually come in two biologically distinct flavors, which derive from different pathways of germ cell neoplasia. So to put this in context, testicular germ cell tumors are divided into three major developmental pathways. The first pathway is on the left-hand side, derives from benign germ cells, and typically occurs in the prepubertal testis, but can present at a later age. And this pathway is capable of generating epidermoid cyst, prepubertal type teratomas, and prepubertal type yolk sac tumors, which are all shown on the left. Intestinal tissue within these teratomas can give rise to well-differentiated neuroendocrine tumors, as we'll see. The second pathway in the center is what we're used to seeing on a daily basis. These tumors derive from germ cell neoplasia in situ and give rise to the 5 major malignant germ cell tumor subtypes: seminoma, embryonal carcinoma, malignant teratoma, yolk sac tumor, and choriocarcinoma. Tumors in this pathway typically have gains involving the short arm of chromosome 12, most commonly as an isochromosome 12p, which can be demonstrated by FISH. Again, intestinal tissue within these teratomas can give rise to well-differentiated neuroendocrine tumor. The third pathway is the least common and derives from maturing sperm and shows the triphasic histology of spermatocytic tumor, most of which are benign, but they can rarely transform into sarcomas. And what's very useful about this framework is that it reminds us that in pediatric patients, the differential diagnosis is really just limited to the 3 entities on the left-hand side. And importantly, well-differentiated neuroendocrine tumors can arise from either of these first two pathways, emphasizing that there are really two distinct types of testicular neuroendocrine tumors, which parallels perfectly the two distinct types of testicular teratomas. Just because these are so rare, I wanted to share a case of a spermatocytic tumor with the typical triphasic histology outlined in red with speckled chromatin and pink cytoplasm, which in this case was nearly entirely overgrown by a malignant spindle cell sarcomatous component, which is enlarged in blue. This is an extremely rare example of a spermatocytic tumor with sarcomatous transformation. So to emphasize the importance of age in the differential diagnosis, I remind you that in prepubertal patients, the differential diagnosis of testicular germ cell tumors is really limited to epidermoid cyst, prepubertal type teratoma, and pure yolk sac tumor. Therefore, a teratoma or a well-differentiated neuroendocrine tumor that occurs in the testis of a child is almost certainly derived from this pathway, the benign germ cell pathway, rather than from germ cell neoplasia in situ. So age alone can be a very helpful feature. But once you're dealing with an adult, the differential diagnosis expands all the way back out again to include tumors derived from all three pathways, because prepubertal type tumors can be encountered in adults. So if we encounter a well-differentiated neuroendocrine tumor in the testis, assuming we're able to exclude a metastasis, the most important question is whether the tumor is derived from the prepubertal pathway, as outlined in green, or if it's derived from germ cell neoplasia in situ, as outlined in red. So to summarize, there are two fundamental types of testicular teratomas and correspondingly two types of testicular well-differentiated neuroendocrine tumors. So let's just compare and contrast them here side by side. So prepubertal type teratomas originate from benign germ cells through this process of parthenogenesis or self-fertilization. They're biologically benign. They can present in pre or post-pubertal patients. They lack gains of chromosome 12p. They're never associated with other malignant germ cell tumor components. The background testis should either be immature pediatric tubules or normal adult spermatogenesis, and the teratoma itself should be completely bland and organoid. In contrast, post-pubertal type malignant teratomas originate from germ cell neoplasia in situ. They're malignant by definition. They're vanishingly rare in children, and the vast majority show gains of chromosome 12p. And histologically, they can be pure or they can be associated with other malignant germ cell tumor components, which obviously makes the differential diagnosis a lot easier. And the background testis is usually abnormal in some fashion with either calcification, scar, or Sertoli-only components. And the teratoma itself can either be bland or can have a cytological atypia. So here's a case of an orchiectomy from a 1-year-old male with a teratoma with a cystic epithelial lining in a background of benign immature seminiferous tubules, a very useful indication that this is a benign teratoma. Background testis shows immature germ cells that do have halos of clear cytoplasm, but the nuclei are perfectly round, and the chromatin is even and speckled, and the huge nucleoli of germ cell neoplasia in situ are lacking. And importantly, germ cell neoplasia in situ is vanishingly rare in such a young age. We have benign seminiferous tubules at the left, adjacent to ciliated respiratory epithelium, diagnostic in this age group of a benign testicular teratoma of the prepubertal type. So the diagnosis becomes much more challenging in an adult because statistically, the vast majority of testicular teratomas in adults are malignant and derived from germ cell neoplasia in situ. And in this case, from a 28-year-old male, we have a cystic space lined by extremely well-differentiated intestinal epithelium, well-formed crypts with interspersed goblet cells lying on top of a well-formed muscle layer, indistinguishable from non-neoplastic intestinal mucosa without context. Background testis shows normal spermatogenesis. There's no calcification, scar, or germ cell neoplasia in situ. So this is an example of a prepubertal type teratoma occurring in an adult male. Again, because the vast majority of teratomas in adults are malignant, this diagnosis should be made with caution, and it's prudent to make sure that isochrome 12p is absent by FISH because malignant teratomas can also be extremely bland. So to recap, the patient demographics and the histology of the background testis are just as important as the tumor itself when we're trying to distinguish between a pre and post pubertal type teratomas and by extension, well-differentiated neuroendocrine tumors. And there are three potential types of background testis: a background of immature testis in a pre-pubertal patient, as highlighted in green, is the typical setting for a benign prepubertal type teratoma. Benign or malignant teratomas can be seen in adults, but a background of normal spermatogenesis, as shown in the center of the slide, is a prerequisite for diagnosing a benign teratoma in an adult, whereas a teratoma arising in association with germ cell neoplasia in situ, as shown on the right, is malignant by definition. So here is a case of a testicular well-differentiated neuroendocrine tumor in a 55-year-old male. The background testis shows tubules with normal spermatogenesis on the upper right, and a neoplasm growing in cords, tubules, and nests on the left, with these basally oriented magenta neuroendocrine granules as outlined in green. Elsewhere in the lesion, there was squamous lined cyst filled with keratin debris, as shown in the upper right in the blue, and cystic ciliated respiratory epithelial glands outlined in red on the bottom right. And note the well-differentiated neuroendocrine tumor at the bottom, outlined in black and enlarged at the bottom left, showing nested architecture, typical salt and pepper chromatin, and amphiphilic granular cytoplasm. In this case, the neuroendocrine tumor was strong and diffuse for synaptophysin, confirming neuroendocrine differentiation, and it also showed diffuse expression of CDX2, likely indicating origin from intestinal tissue of an underlying teratoma. And FISH for isochrome 12P was negative, consistent with a well-differentiated neuroendocrine tumor arising from a prepubertal type teratoma, in this particular case, in an adult patient. So here's another case of a testicular well-differentiated neuroendocrine tumor in an adult with a background of normal spermatogenesis. In this case, there were no other components identified, but presumably the tumor has overgrown an underlying teratoma. Although this is entirely consistent with a primary testicular well-differentiated neuroendocrine tumor, metastasis should be excluded clinically. And the presence of lymphovascular invasion or microscopic tumor outside the testis would increase our suspicion that we could be dealing with a metastatic lesion, but ultimately clinical and radiographic correlation would be required. So in summary, there are two different types of testicular teratomas, pre and post-pubertal types, and each can contain intestinal tissue that could give rise to a well-differentiated testicular neuroendocrine tumor, although it does seem that most testicular well-differentiated neuroendocrine tumors do arise from the prepubertal pathway. And the differences between these two types of testicular neuroendocrine tumors mirrors the contrast between pre and post-pubertal type teratomas, as we discussed earlier. And neuroendocrine tumors arising from the prepubertal pathway have an excellent prognosis, although the number of reported cases is limited, so some clinical follow-up in these cases seems reasonable. And in contrast, neuroendocrine tumors arising from the germ cell neoplasia in situ associated pathway are considered malignant by definition. And then I also wanted to highlight a new insight from a very recent published series of 5 testicular neuroendocrine tumors. And all of these cases lacked isochrome 12P by FISH, and by next generation sequencing, 2 of them showed either deletions of chromosome 18 or mutations in CDKN1B, as I've outlined in green. And these are recurrent alterations seen in small bowel neuroendocrine tumors, which makes sense given that all testicular neuroendocrine tumors in the study were positive for CDX2, indicative of an intestinal phenotype. So to summarize, testicular neuroendocrine tumors arise from germ cells, but there are really 2 pathways. And if we follow the green arrows, we see benign germ cells form a prepubertal type teratoma with intestinal type tissue, which can give rise to a NET. And if we follow the red pathway, we get development of germ cell neoplasia in situ, which gives rise to a malignant teratoma, which can give rise to a NET. And while these 2 types of neuroendocrine tumors may be indistinguishable at high magnification, the histologic context is different, and the genetics is also distinct, with prepubertal type neuroendocrine tumors lacking 12P gains and some showing loss of chromosome 18, whereas germ cell neoplasia in situ derived lesions have gains of 12P in the vast majority of cases. So the final section will quickly review some mimickers of testicular neuroendocrine tumors. Sertoli cell nodules share a tubular architecture and a pseudoglandular rosette formation, but these are typically incidental findings and testes removed for other reasons, and often there is also neon pink intraluminal material, which I've outlined in black. It's important to remember that Sertoli cell lesions will frequently label a synaptophysin, which can be a pitfall, but inhibin or SF1 staining will confirm sex cord origin, and of course these lesions will also be CDX2 negative. Sertoli cell tumors are probably the most challenging mimicker on H&E, as they can have very similar architecture and cytology. Again, synaptophysin is a pitfall because this can be seen in Sertoli cell tumors. The easiest way to separate them is with SF1, as shown in the upper right. For higher grade Sertoli cell tumors, beta-catenin can be a helpful adjunct, because the vast majority of Sertoli cell tumors have beta-catenin mutations and show nuclear beta-catenin staining. So in the upper left, we see membranous beta-catenin in non-neoplastic Sertoli cells compared to the bottom right, where we have nuclear staining in a Sertoli cell tumor with solid growth. Nodular steroid cell nests are adrenal cortical type cells that have a nested and corded architecture that definitely raises the differential diagnosis of a neuroendocrine tumor. But the location is a useful feature, as these are hilar or paratesticular, and these are thought to be the source of ACTH-driven testicular pseudotumors seen in some patients with congenital adrenal hyperplasia. And also, these are typically a microscopic incidental finding, as was the case in this orchiectomy, which had a seminoma elsewhere. And by immunohistochemistry, these are SF1 positive, which is not an expected feature of neuroendocrine tumors. So the last mimicker I want to quickly highlight is also germ cell derived. As you know, malignant germ cell tumors can give rise to somatic type malignancies, with embryonic type neuroectodermal tumor being a common example. And these are essentially expansile zones of primitive neural tissue within a malignant germ cell tumor, and they frequently have true rosettes recapitulating the embryonic neural tube. But in contrast to neuroendocrine tumors, these are highly proliferative lesions. They label with SOX11, a marker of primitive neural tissue, as shown in the upper right, and they can certainly stain with synaptophysin, but usually it's focal and weak, as seen in the lower right, rather than the diffuse strong staining that is typical of well-differentiated neuroendocrine tumors. Whereas testicular neuroendocrine tumors, as we've discussed, are frequently of the intestinal type and labeled diffusely with CDX2, if you perform a CDX2 stain on an embryonic type neuroectodermal tumor, it will frequently reveal subtle strips of yolk sac tumor, as seen in the upper right, which will correspond to, if you go back to the H&E, a very subtle patch of cells with subtle subnuclear vacuoles and clear cytoplasm, as I've outlined in black, and these are so-called embryonic type neuroectodermal glandular complexes. So to summarize the key points, neuroendocrine neoplasia is a diverse family with 3 major branches, and we talked about the diversity of nets up and down the GU tract. We discussed that testicular neuroendocrine tumors are actually germ cell derived, and even though they're incredibly rare, they're really 2 discrete flavors, which are perfectly analogous to testicular teratomas. And just remember that in the absence of a teratomatous component, clinical and radiographic correlation are needed to exclude a metastatic, well-differentiated neuroendocrine tumor, for example, of GI tract origin. And one final closing point, just to emphasize the importance of clinical context. So on the left-hand side, we've seen how benign germ cells give rise to a tumor that is basically indistinguishable from a GI tract well-diff net out of context. On the upper right is a recent case that I had of a brain metastasis that looked and stained like a pure yolk sac tumor, and without clinical context or history would be indistinguishable from a germ cell tumor. But in this case, there was an extensive history of metastatic rectal adenocarcinoma, and this tumor ended up showing identical mutational profile to the prior rectal tumor, which is actually shown on the lower right. So this is a rare example of yolk sac transformation of a somatically derived adenocarcinoma. And that is to say that, yes, germ cell tumors can mimic somatic type tumors like well-differentiated neuroendocrine tumors, as we've discussed today, but the reverse is also possible. And somatic tumors can acquire, rarely, a yolk sac or trophoblastic phenotype and almost perfectly mimic a germ cell tumor. And in these challenging scenarios, clinical information can be just as valuable as morphology or immunohistochemistry. And with that, I thank you for your attention, and I put my email up here in case you want to contact me. I'd be happy to do so. Thank you so much.
All right. Thank you, Dr. Baraban. As Jeff mentioned, we're gonna answer the question in the end. So that's my great honor to introduce the second speaker, Dr. Andy Acosta. So Dr. Andy Acosta is currently a dedicated genitourinary pathology in Indiana University Health Pathology Laboratory and associate professor of pathology at Indiana University in Indianapolis. He completed his medical school in Argentina, his home country, and completed residency training in anatomic and clinical pathology at the University of Illinois in Chicago, followed by fellowships in genitourinary pathology and surgical pathology at the Brigham and Women's Hospital in Boston. Dr. Acosta's research focuses on non-germ cell tumors of the testis and the clinical aggressive phenotypes of germ cell tumors resistant to systemic therapy. He has published numerous research papers on those topics and is currently authoring chapters, sections on germ cell tumors and the cord-stromal tumors in several reference books. Dr. Acosta has been a speaker at multiple international conferences in the United States, Latin America, Europe, and Asia. Dr. Acosta will be speaking on the topic, cord-stromal tumors of the testis, recent updates and basic practice recommendations for diagnosis and prognosis. Okay,
Thank you
Dr.
very much.
Acosta, floor
Thank
is
you very
yours.
much. Thanks for the introduction, and I'm truly grateful to the organizing committee for inviting me to be part of this session. I don't know if you can all see my screen. Can you all see my screen and my pointer? Okay, so let's get started. In this presentation, I will talk about recent updates and basic practice recommendations for diagnosis and prognosis of cord-stromal tumors. This will be a very practical talk based mostly on the recommendations. There are not going to be a lot of pictures, but I will try to give a general background of each topic. I have no conflicts of interest. And just as a general concept, when we talk about cord-stromal tumors, we talk about tumors that derive from or show differentiation to two different compartments in the testis. One is the derivatives of the sex cord, which in the case of the testis are Sertoli cells, or components of the testicular stroma that is between the seminiferous tubules. So you have some tumors that have a pure sex cord phenotype, and the prototype of that is Sertoli cell tumor, whereas others have a pure stromal phenotype. And of course, there's a third category of tumors that have either an uncertain phenotype or mixed phenotype, that is, that they include both sex cord and stromal elements. Overall, these tumors are rare. They represent about 3 to 5% of all testicular tumors, and some are associated with overproduction of sex hormones, and this leads usually to precocious isosexual pseudopuberty in children, whereas in adults, most of these tumors will present as a testicular mass, although in a smaller subset, we can have manifestations of sex hormone production, such as gynecomastia. Only a few types have been associated with potential precursor lesions, and importantly, with some relevant exceptions, most of these tumors are mostly benign, not always, but mostly benign, and there's one subtype that is mostly aggressive. Because they are mostly benign, they are amenable to conservative surgical management, that is to partial orchiectomy, and this is a practice mostly in children, but it's something to keep in mind because you might get frozen sections of these tumors. And the question comes, when it comes to mind, when you think about it, if you think about the fact that most of these tumors are benign, why should I care about subclassifying testicular sex cord-stromal tumors? Well, this is important for several reasons. First, because there's a subset, and this is a significant subset, that is associated with inherited cancer predisposition syndromes, and in these patients, the testicular tumor can be the first manifestation of the syndrome and therefore the opportunity to diagnose the syndrome in the first place. Another important reason is because some of them are associated with important underlying medical conditions. The classical example is the testicular tumors of the androgenital syndrome in the case of congenital adrenal hyperplasia. And of course, we need to recognize those subtypes that have malignant potential because, of course, this will require surveillance. And if we think that there's a high chance that they can be malignant, they will also require a more aggressive management approach. And whenever I, in general, in my practice, whenever I'm faced with a tumor, I like to put it in this category of whether it's problematic, intermediately problematic, or non-problematic. And this is a scheme I usually use where I classify the tumors as problematic based on the chances they have of being malignant. And I think the tumors at the extreme, meaning that the ones that are always malignant or always benign, are non-problematic, right? Because I mean, clinicians know how to treat them. They are aggressive here, conservative here, and there are no major questions. And somewhat the same is true for those that are mostly malignant, because being aggressive is sort of justified in those cases. Whereas those tumors that are mostly benign, although there's a significant subset that is malignant, are the ones that are truly problematic, especially if we don't have good ways of telling apart the ones that are going to be aggressive from the ones that are not. And if we look at sex cord-stromal tumors of the testis, we will see that most of the tumor types fall within the spectrum of problematic tumors, and that most of them are benign, although there's a subset that is malignant, and that subset that is malignant is quite difficult to manage because they don't respond to systemic therapy typically. And another problem with sex cord-stromal tumors is that they show significant morphological overlap. For example, here I'm showing you 5 pictures. And if I tell you that here there's an example of large cell calcifying Sertoli cell tumor, an intratubular large cell hyalinizing Sertoli cell neoplasia, Leydig cell tumor, and Sertoli cell tumor NOS, it would probably be hard to tell which one is which. So here you can see, for example, that the one on the left, which I would have guessed initially that it could be a large cell calcifying Sertoli cell tumor, is a Leydig cell tumor with calcifications. On the right, we have an example of an intratubular large cell hyalinizing Sertoli cell neoplasia with invasive components, which may fool you into thinking this is a large cell calcifying Sertoli cell tumor or a Leydig cell tumor. The Sertoli cell tumor NOS is perhaps the one that you could recognize up front. In the center, you can see a large cell calcifying Sertoli cell tumor that is purely intratubular and therefore would have made you think of an intratubular large cell hyalinizing Sertoli cell neoplasia. And on the right, you can see a large cell calcifying Sertoli cell tumors without calcifications, which would make you think of a Leydig cell tumors. So given this significant morphologic overlap, the distinction between these tumors is quite difficult, although it's very relevant because the syndromic associations and malignant potentials of these tumor types may sometimes be different. And because in recent years, several studies have been published about the molecular background of these tumors, and in particular about their genomic and epigenomic characteristics, recently both this society and ISUP joined efforts to gather a group of experts to issue recommendations for workup and a classification of these tumors based on this new molecular information. And this group was called TEST, for testicular sex cord-stromal tumor. And what I'm going to present in this short presentation is a summary of the most important recommendations, but of course, it's not a complete summary. So I refer the audience to the original recommendations paper if they want more information about more rare tumor types. So let's start with some general recommendations. The group recommended that immunohistochemistry be used to establish sex cord-stromal lineage or sex cord-stromal differentiation on most tumors, especially for pathologists that don't see many of them. Second general recommendation is to not extrapolate the staging system, the TNM staging system that we use for germ cell tumors. And this is true, at least for the time being, based on the fact that we have no information or no data of whether this system is prognostic for sex cord-stromal tumors. For instance, some testicular tumors of the androgenital syndrome, which tend to arise in the testicular hilum, may extend into the hilar fat, and that would make you classify it as a T2 when we know that these tumors are invariably indolent or benign. And then we recommend to avoid using the terms benign or malignant for primary tumors in most instances, especially in adult patients, because there are plenty of examples of tumors that look histologically benign and eventually metastasize, and the other way around, there are primary sex cord-stromal tumors that have aggressive histopathologic features and never metastasize. So regarding immunohistochemistry, since the recommendation was issued, the immunostains that most labs have are the ones that I'm showing here. And as you may know, some are general markers such as SF1 and inhibin, whereas others such as WT1, SOX9, and FOXL2 are markers that tend to be positive specifically, or more commonly, not specifically, more commonly in tumors that have a sex cord phenotype. And because the sex scores derive from the coelomic epithelium, just as the mesothelium of the peritoneum does, you will see that there's a lot of overlap with the markers that we use for mesothelial lesions. But as a general recommendation from a personal viewpoint, if you have to use 2 markers to establish sex cord-stromal differentiation, I recommend using SF1 and inhibin, because overall, considering all tumor types, they are the most sensitive, especially SF1, and it's a clean nuclear stain. So now let's go over the recommendations for Leydig cell tumor. Let me give you just a brief background before I start with the recommendations. Leydig cell tumors are the most common sex cord-stromal tumor type in men, and 90% are benign, and the rest are malignant, meaning that they metastasize, and these are very difficult to manage because they don't respond to systemic therapy. And a problem with this tumor type, as with others in this category, is that predicting malignant behavior exclusively based on histopathologic findings is suboptimal, because as I've said before, there are cases with no aggressive features that eventually metastasize and vice versa. And recently, there were a couple of studies that demonstrated that Leydig cell tumors may be associated with FH deficiency, and in some of these cases, the patients have evidence of HLRCC or germline FH mutation. And it's also been seen that FH deficiency is enriched in tumors with aggressive histopathologic features or with malignant clinical behavior. And also recently in genomic studies, it's been shown that malignant Leydig cell tumors, that is tumors that have metastasized, are enriched for MDM2 amplification, which is seen in 30 to 50% of these metastatic cases. So the first recommendation is that FH assessment should be performed on primary Leydig cell tumors with aggressive histopathologic features, and usually I recommend doing it when you have 2 or more, although again, this worrisome histopathologic findings are not weighted, and in my opinion, for example, if you only have tumor necrosis, that's worrisome enough, and in that cases, I do FH even with 1 worrisome finding. And the reason to perform FH immunohistochemistry or FH assessment in this context is both as a predictive marker and to identify cases that could be linked to potential germline alterations. We also recommend doing FH immunohistochemistry or FH assessment on metastasizing Leydig cell tumors. And of course, the goal here is not to use it as a predictive marker because the tumor has already metastasized, but to identify tumors that could be potentially associated with HLRCC or germline FH mutations. And the spectrum of this FH deficient Leydig cell tumors, in my experience, is somewhat wide. You have some tumors with some significant atypias, the one that you can see here with prominent cherry red nucleoli, and you can probably distinguish some subtle perinucleolar halos. Again, you can see the loss of FH expression on the right. But some other tumors that metastasize, such as this one, have very bland histology, not very many mitosis, and the only clue to their potentially aggressive behavior is loss of FH expression. And the group has also recommended that these tumors with FH deficiency be classified as FH deficient Leydig cell tumor. And again, this is to highlight that these tumors are linked to a potentially germline FH variant, and this may prompt the clinicians to think about further assessment of these patients. And also, of course, to highlight the possibility that these tumors will behave aggressively. And the group, again, based on recent genomics findings, has recommended that MDM2 assessment be performed on primary Leydig cell tumors with aggressive histopathologic features, again, typically 2 or more. And this is to be used as a predictive marker because we've seen that this alteration is enriched in metastatic tumors, but we've also seen it in a couple of primary tumors with aggressive histopathologic features. And you can do it by assessing the tumor with immunohistochemistry. Although, to be honest with you, in our lab, MDM2 immunohistochemistry is not the best. And I think that is the experience of many of my colleagues. So some of them reflect the tumors directly to fish, as you can see on the left. So now let's go over some recommendations for Sertoli cell tumor NOS. Let me give you again a little bit of a background. Sertoli cell tumors NOS are by definition a pure sex cord tumor, and they are driven largely by beta-catenin mutations. Most of these mutations, or I would say pretty much all of the ones that I've seen, happen in the hotspot region of exon 3, and these beta-catenin mutations are found almost invariably in primary tumors. And another important thing, as you will see later in the presentation, is that there's a subset of clinically malignant Sertoli cell tumors NOS that show some morphologic overlap with seminoma, and we will discuss that in greater detail in a few slides. But again, going back to the topic of beta-catenin mutations in these tumors, as you can see in this illustration, primary tumors, which I want the ones in the box here, pretty much always demonstrate evidence of gain-of-function beta-catenin mutations, and this includes tumors without aggressive histopathologic features and tumors with aggressive histopathologic features. And this correlates with diffuse nuclear expression of beta-catenin. And the expression here is diffuse in every cell nuclei, which is consistent with the VAF of these variants that are indicating a clonal alteration. And that's different from what we see in Leydig cell tumors, which may also have beta-catenin mutations, but beta-catenin mutations in Leydig cell tumors are typically a subclonal event, meaning that it's only present in subsets of tumor cells, and therefore beta-catenin expression in Leydig cell tumors with beta-catenin mutations tends to be either focal or multifocal, as you're seeing in these pictures. So based on the very strong association of Sertoli cell tumor NOS with beta-catenin mutations, the group has recommended that if you have a primary testicular sex cord tumor that doesn't have diffuse nuclear beta-catenin expression, the diagnosis of Sertoli cell tumor NOS should be made only if there's prototypical morphology. And by prototypical morphology, we mean evidence of sex cord differentiation in the form of tubular architecture. But if you looked at the prior illustration in detail, you'll notice here that there are two Sertoli cell tumors with inactivating mutations or truncating mutations of APC, and there was evidence of loss of heterozygosity in these cases. And because we know that APC is linked, germline APC alterations are linked to FAP, we wondered a few years ago whether Sertoli cell tumors could be actually associated with germline APC alterations. And to prove that, what we did is in patients with these tumors, we sequenced in parallel non-neoplastic and neoplastic tissue showing that a germline APC alteration with loss of heterozygosity in the tumor was the driver of these tumors. So keep this in mind, and some of these patients had evidence of FAP. So there's a potential link between sex cord-stromal tumors and Sertoli cell tumors in particular, and germline APC alterations. And unfortunately, these tumors look exactly like APC wild-type tumors, that is, those driven by beta-catenin, with the only exception that in two of these patients, we saw that the tumors were either multifocal or bilateral. And on the right, you can see, in fact, one of the multifocal tumors where one was a typical Sertoli cell tumor NOS with tubular architecture, and the other one appeared to be an intratubular Sertoli cell lesion. So based on all these findings, the group recommends that if you have a bilateral or a multifocal Sertoli cell tumor NOS, which would be otherwise exceptionally rare, you consider assessing APC status, and this is mostly by sequencing the tumor if possible. These are so rare that I think this is probably justified. So now going back to the issue of this malignant Sertoli cell tumors, or what we used to classify as malignant Sertoli cell tumors that show morphologic overlap with seminoma. Here you're seeing an example of one of these tumors where you can understand why many of these tumors were actually misdiagnosed as seminoma. They are mostly solid, associated with very prominent inflammatory infiltrates, and they don't necessarily look like typical Sertoli cell tumors NOS. On the right, you can see that the stroma of these tumors tends to be collagenous and very thick, and the architecture is typically nested with small to intermediate sized nests. But when you start looking at these tumors more closely, you see that there are significant differences with seminoma because the lymphoplasmacytic infiltrate is not the only infiltrate that these tumors have. Usually within the tumor parenchyma, you tend to see neutrophils and eosinophils in some cases as well. And of course, the nuclei are different from the nuclei of seminoma. They are not so squared off, and the nucleoli are smaller, and mitotic activity is usually significantly lower in these tumors than in seminoma. And of course, they express sex cord stromal tumor markers such as SF1 and inhibin, and they are going to be negative for SAL4. But they have a sort of a peculiar immunophenotype when you compare it with other sex cord stromal tumors, in that they tend to express CD30 diffusely and strongly, and they are almost always positive for EMA. And on the left, you can see that unlike most Sertoli cell tumors NOS, these tumors are not driven by beta-catenin mutations, and they show membranous expression of beta-catenin. And more recently, now in the era of next-generation sequencing, a study demonstrated that the overwhelming majority of these tumors that show morphologic overlap with seminoma are driven by a fusion of EWSR1 and ATF1, or in some cases where this couldn't be assessed, EWSR1 rearrangements by break-apart FISH were demonstrated, again suggesting that they are driven by EWSR1 gene fusions. So the recommendation of the group is whenever you see one of these sex cord stromal tumors that shows morphologic overlap with seminoma, you perform assessment for EWSR1 rearrangements with FISH or EWSR1 ATF1 fusions, and this ideally with RNA sequencing, although there's a fusion-specific FISH available as well. And again, I don't think this is 100% necessary. Of course, it's ideal to have it to make this diagnosis, but I think the tumor has morphology and an immunophenotype that's recognizable enough that you can at least strongly suggest a diagnosis without having the molecular information. And then for classification, we recommend that these tumors be separated from Sertoli cell tumor NOS and classified as a different entity. And it's specifically, I find it useful to specify and note that these tumors are thought to be invariably malignant. And that's the reason to classify them separately, because if you say Sertoli cell tumors NOS, the clinician might interpret that this tumor has a 90% chance of being benign and only a 10% chance of being malignant, whereas we know that inflammatory and nested testicular sex cord tumor is invariably malignant. Now let's go over some recommendations for large cell calcifying Sertoli cell tumor. First, let me give you a little bit of background. These tumors are variably associated with the Carney complex. The frequency of this association in the literature varies from 10 to 40% in different studies. And the tumors that we see in the context of the Carney complex are typically bilateral, multifocal, and of course they will present in younger patients, and they tend to be benign. Whereas about 10 to 20% of the ones that we see in patients that are non-syndromic can have aggressive behavior. Importantly, they can be the first manifestation of the Carney complex, and they often are in these patients, and that's why this diagnosis is important, because it may lead to diagnosis of the Carney complex. And there are rare cases that have been reported in patients with the Poy-Jaeger syndrome, but in my opinion, these are most likely tumors that are driven by STK11 and not true large cell calcifying Sertoli cell tumors. We can discuss that during the time allotted for questions if you want. And most of the tumors that are malignant occur in patients that are older than 25 years. And recently, 2 separate series have demonstrated that the overwhelming majority of these tumors, whether they occur in the context of the Carney complex or sporadically, show evidence of inactivation of PRKR1A, typically by a truncating mutation and copy loss of the wild type copy, but sometimes we copy neutral loss of heterozygosity as well. And this is something that we commonly see in tumors that are associated with the Carney complex, in which the tumors associated with the Carney complex are PRKR1A deficient, but also the ones that are sporadic and have the same histopathologic features tend to have PRKR1A inactivation. And these tumors are somewhat easy, I would say, to identify once you've seen a couple, because they have this very coarse, mulberry-like laminated calcifications. They're very typically myxoid stroma that is heavily infiltrated by neutrophils. But keep in mind that there's a significant subset, about 20% in our experience, that don't have these features. For example, here you're seeing an example of a large cell calcifying Sertoli cell tumor without calcifications. Or here you're seeing another one without calcifications and without the typical stroma. And the only clue here were the presence of only scattered neutrophils, right? So fortunately, this is a tumor type that due to its genomic alterations, we now have a good marker for with immunohistochemistry, which is PRKR1A in immunohistochemistry. And we've shown that this immunostain is very sensitive and very specific for distinguishing between this tumor and potential mimickers. So the group has recommended that PRKR1A assessment is desirable, but of course not necessary to support a diagnosis of large cell calcifying Sertoli cell tumor, especially in this subset of cases that show unusual histopathologic features. And with that, I conclude. I thank you all for your attention, and I leave you with a picture of the GU group here at Indiana University. Thank you.
Thank you, Andy. Very nice presentation. And just remind the audience that we will take all the questions at the end of all 3 lectures. And
Sure.
please submit them through the Q&A tag in the Zoom. So now we are welcoming the 3rd speaker of this virtual education series, and that's Dr. Christopher Przybycin. He received his MD from University of Michigan Medical School, followed by residency in anatomic and clinical pathology at University of Michigan. He subsequently completed fellowships in surgical pathology, gynecologic pathology, and GU pathology. Chris joined the staff of the Cleveland Clinic in 2012, where he practices GU pathology. Chris has published numerous peer-reviewed articles in GU pathology, and his main research interest has been in kidney tumor and testicular pathology. He's the author of several chapters, including the non-neoplastic testicular pathology chapter in Sternberg's Diagnostic Surgical Pathology textbook, as well as the acquired cystic disease-associated RCC section of the 2012 WHO classification. Chris has a strong interest in teaching and has served as the director of the GU Pathology Fellowship at the Cleveland Clinic since 2018. He will be speaking on the topic, Paratesticular Epithelial Tumors, Pathologic Classification and Diagnostic Workup. Chris, please.
Okay, great. Thank you so much. I really appreciate this opportunity. Thank you for the invitation to give this talk. And let me share my screen while I'm doing that. Oh, someone else is sharing, it looks like. It won't let me share.
I think it's Andy. Would you mind please unshare?
Can you see it now?
Let me try again. It still says someone else is sharing, and I can't.
And Andy, could you? Yeah.
Yeah. I'm trying to. Is that,
Okay. I think
great.
that
my apologies.
that's okay. All right, cool. Oops. Okay. Hopefully you can see. No, I didn't want to. Sorry. I didn't think I would have to do that again. There we go. Okay.
Yeah, it's all good.
All right. Yeah, I'm still Chris Przybycin. I'm from the Cleveland Clinic. I do GU pathology there. Thank you again for this invitation. So I'm going to talk about epithelial lesions of the paratesticular region. When I was first asked to give this talk, I thought, well, this is great. Some of you who know me know that I play Dungeons and Dragons. This is a relatively obscure topic. I thought, well, this is exciting because I'll get to grab a torch and search the underground archives, which is what I would say if my hospital was cool enough to have an underground dungeon library. But unfortunately, the Cleveland Clinic Library is next to a parking garage, and it's lit by fluorescent light, so that I had to sort of pretend. But what I did find during my researching this material is that there's actually a lot written about this topic. And at first glance, you might not think this is necessarily a difficult diagnostic problem because there's only a few general categories here. So why would it be difficult? So we have mesothelial tumors, we have Mullerian tumors, tumors of the reedy testis and the epididymis, and then metastases. Those are the main categories. But so why is each of those categories somewhat difficult? Well, mesothelial tumors can be difficult because there are these more recently described sort of intermediate categories that have strict diagnostic criteria. And why are Mullerian tumors difficult? Well, Mullerian tumors are difficult because the full spectrum of cell types that you can see in the ovary, for example, mucinous, serous, et cetera, you can see in the paratestis, as well as all the levels of malignancy from benign to borderline to carcinomatous. Why are reedy testis tumors difficult? Well, they're extremely rare, and they're essentially a diagnosis of exclusion. And so nobody has like a ton of experience with these. And then metastases, they have their own set of diagnostic challenges, which we'll talk about towards the end of the talk. And then amongst all of these categories and entities, there's a decent degree of immunohistochemical and morphologic overlap also. So that can make it difficult. So when I was researching this, what I found was that there's actually several large series that have been done on epithelial tumors of the paratestis, and then other additional large series that have been done with like individual cell types like mesothelial tumors or series of serous tumors, for example. So I'm trying to like condense that into a digestible format. I won't have enough time to get through everything, but I'll try to give sort of an overview of as much as I can. So then if we're thinking about paratesticular tumors, I think it's important to define what the paratestis is and what structures are present there. Because if you know what's present there, then you know what cell types you're looking for, which directs what morphologic considerations you're making, and also directs your relevant immunohistochemistry. And since we're talking about epithelial lesions here, we're going to be concentrating on the sources of epithelial lesions here. So reedy testis, epididymis, the testicular appendages, and the mesothelium mainly. This is a helpful figure from the most recent WHO classification that I think gives you a nice schematic of where the different tumors are arising from in the paratesticular region. And so you can see that the mesothelial surfaces here give rise to the full spectrum of mesothelial tumors. We have tumors arising from the reedy testis, both benign and malignant. I'm trying to minimize this a little bit here. Okay, there we go. Both benign and malignant arising from the reedy testis and the epididymis. And then we have Mullerian neoplasia that is thought to be arising either from Mullerian remnants like the appendix testis, or possibly from Mullerian metaplasia of the peritoneum. This is a little schematic that I made from a huge series reflecting a 32-year experience of 146 cases at a single institution, just to give you an overview of the relative distribution of lesions and their frequency here. So there were 146 total cases. The green cases represent the benign lesions, which accounted for over half. It was 106 of those cases. And you can see most of them were either adenomatoid tumors, benign cysts, or mesothelial hyperplasias with a few other entities. There were fewer malignant tumors here, and of the malignant tumors, most of them were mesotheliomas with a smaller contribution from, for example, serous carcinomas or reedy testis adenos. And then the smallest category were borderline tumors, of which most were serous borderline tumors. So I'm going to start with mesothelial lesions. This was an incidental finding in a hydrocele sac that I recently had. This is quite possibly the only interesting thing I've ever found in a hydrocele sac, but because it gave me like a nice picture that I could use for an upcoming talk. But basically, you can see a superficial cellular proliferation without any underlying invasion. And this is an example of reactive mesothelial hyperplasia. This is an incidental finding. It can be pretty florid. There should be no significant atypia or necrosis, so you can see that there's pretty bland cytomorphology here, limited mitotic activity as a rule, and there should be no underlying invasion. Hopefully you agree with me, or I'm going to have to go amend a report. So this is a related example. So this is you can see a section of an orchiectomy specimen here. And we've got this little free-floating, well-circumscribed nodule. And if we look at higher power, it's pretty cellular. And it's actually composed of two cell types here that are both cytologically bland. So we've got this population of cells that has bland nuclei, maybe kind of wrinkled contours and abundant cytoplasm. These are histiocytes. And then we've got an admixed population of mesothelial cells with cuboidal look and relatively scant cytoplasm. And that's borne out by immunohistochemistry for mesothelial markers. You can see admixed cells that are positive for calretinin and CK5-6. And so this is an example of a lesion that's gone by numerous terms and is present in numerous sites in the body. We probably would use the term nodular mesothelial histiocytic hyperplasia, but it's been called mice, like if it's cardiac, which is kind of cute. But this is a benign lesion. So then once we're beyond the spectrum of reactive lesions, now we're looking at things that are definitively neoplastic amongst mesothelial tumors. We have a spectrum here from definitively benign tumors, adenomatoid tumors, to tumors that are definitively malignant, like malignant mesothelioma. But there's also a few entities that are sort of intermediate. They have strict diagnostic criteria. Their prognosis is somewhat indolent or maybe still a little bit uncertain. And that would be the well-differentiated papillary mesothelial tumor and what has been called mesothelioma of uncertain malignant potential, or more recently been suggested to be called complex mesothelial tumor of the tunica vaginalis. And we'll talk about those. So this is an example of one of the most common paratesticular epithelial neoplasms that we encounter. This would be usually at the head of the epididymis. And you see these tubules that look like vascular spaces with this attenuated flattened epithelium. You've got hobnailing nuclei, and you have these bridging strands, these thread-like bridging strands across the tubules. In other areas, you have diffuse infiltration and maybe more abundant cytoplasm. So this is an example of an adenomatoid tumor. It's benign, but we have areas that look infiltrative and alarming in appearance. So adenomatoid tumor then is the most common testicular adnexal tumor that we see. Because it's mesothelial in origin, as expected, it's positive for mesothelial markers. BAP1 immunohistochemistry is retained. That's a marker that is sometimes lost in some mesotheliomas. These tumors have TRAF7 mutations, which can be tested for if it's some diagnostic uncertainty. And why do adenomatoid tumors pose some diagnostic challenges sometimes? Well, one is that you have to think of it. You've got a tumor that looks really infiltrative and scary, and if you're not careful, you could consider it to be a carcinoma. The other thing that happens is they often infarct. which lends an even scarier appearance. This is another example that we had that the surgeon knew what this was just from experience. This was a well-circumscribed nodule attached to the head of the epididymis. You can see it's really well circumscribed and nodular, and you can see lymphoid aggregates, which are often present in adenomatoid tumor. Another example that looks a little scarier because there's central infarct and it's actually growing into the testis. And at higher power, if we look at the interface between dead and alive, you can sometimes pick out some recognizable viable foci of adenomatoid tumor here, but these all make it difficult to diagnose. And then other areas in that same tumor, again, with an infiltrative appearance, if you were to do a cytokeratin, you might scare yourself. If you're thinking about a mesothelial lesion, then you can apply calretinin and HEG1. Hopefully the morphology should get you close enough, but these can help you. Moving farther along the spectrum of mesothelial neoplasms, now we've got an exclusively papillary lesion that is composed of these edematous or hyalinized or fibrous stromal cores lined by a single layer of bland cuboidal epithelium and no invasion of the underlying tissue. And so this is an example of well-differentiated papillary mesothelial tumor. This, because it's supposed to be indolent, should require strict criteria to diagnose. We don't see it very often in this region. And when it is diagnosed, it would ideally be localized. And I probably would only diagnose it if it's solitary. I'd be very scared if it was multifocal. It should, as I said, have an exclusively papillary architecture with no invasion and have a single layer of bland cuboidal cells. As you would expect, there should be minimal mitotic activity. And then two markers that, as I mentioned, are sometimes lost in mesothelioma, BAP1 and MTAP, should be retained in well-differentiated papillary mesothelial tumor. And thus far, in published experience, they have shown indolent behavior. So why is that potentially challenging? Well, one is that you have to maintain strict criteria. And the reason for that is that mesotheliomas, malignant mesotheliomas, can actually have foci that are histologically identical to well-differentiated papillary mesothelial tumor elsewhere in the neoplasm. So you have to take into account the context and make sure you're sampling well. The other is the possibility of what's been called mesothelioma in situ. This has been described in the pleura. As far as I know, currently it's only a theoretical possibility in the paratestis, but I wouldn't be shocked if somebody publishes one of these someday, or maybe I just missed it. But this is a tumor that looks like well-differentiated papillary mesothelial tumor, but has lost BAP1 expression. The reason that's important is when you have that in the pleura, most of those tumors develop into mesothelioma, or at least at a very high rate. So some authors have noted cases that resemble well-differentiated papillary mesothelial tumor, but are actually a little bit more complex. So here we have a tumor that has this papillary architecture. It's got a single layer of cuboidal cells along most of the papillary cores, but we have this underlying complex glandular, or epithelial, I should say, proliferation. So you have these anastomosing cords. There's some hyalinization of the stroma under here. You've got tubules that are kind of crowding together. They can have a cribriform appearance. But the important thing to know and to notice is that while you do have this proliferation throughout the stroma of the papillary cores, or the stalks here, if you were to look at this at low power, you don't have any invasion of the underlying tissue. And so that's what distinguishes this from a malignant lesion. So then we have this sort of intermediate concept where you have something that looks like a well-differentiated papillary mesothelial tumor, and then you add to that some complex architecture that is actually not invading the underlying soft tissue, and you come up with what has been described as mesothelioma of uncertain malignant potential, or as I mentioned in the most recent series, has been suggested to be called complex mesothelial tumor of the tunica vaginalis. The proposal for the name change is basically because in the cases that have follow-up so far, there haven't been any adverse outcomes. How do these present, whatever you want to call this intermediate lesion? Well, they present like you would expect any other mesothelial tumor in this region to present, usually with a hydrocele or a scrotal mass. It's hard to get a lot of history on asbestos exposure, but sometimes it's there. So really, if we're looking at the morphology, this lesion should have areas that look like well-differentiated papillary mesothelial tumor, accounting for variable proportions of the tumor, and then complex architecture under the surface, but that is not invading the underlying tissue. So no invasion or desmoplasia. Really shouldn't have much in the way of atypia and mitotic activity, ideally. Why is this hard? Well, it's really scary to allow some level of complex architecture in a mesothelial lesion without calling it malignant. What happens to these things from an immunohistochemical standpoint? As you might expect, for a benign mesothelial lesion, they have retained expression of BAP1. I've mentioned MTAP also. That's an immunohistochemical surrogate for alterations in CDKN2A, which is commonly, sometimes mutated in paratesticular mesotheliomas. But those, as you would expect, are retained in this lesion. And thus far, the reported cases in the literature have had no adverse outcomes. More recently, there was a proposal to add on Merlin staining as a surrogate for NF2 mutations. So as we're going to talk about in a minute, NF2 mutations are actually more common in paratesticular mesotheliomas than BAP1 alterations or CDKN2A mutations. Two publications so far that I've seen have proposed using Merlin staining, retained Merlin expression to indicate that you don't have NF2 mutation, and thus another piece of evidence that you could safely diagnose it as mesothelioma of uncertain malignant potential, or the other name that's very long. Okay. Paratesticular mesotheliomas, we're still talking about rare tumors. You may or may not get a history of asbestos exposure in these patients, and the clinical presentation is essentially nonspecific. But among paratesticular mesotheliomas, when they do occur, they're usually epithelioid, and that can have a variety of architectural patterns. They can occasionally be biphasic, and on the next slide, I'm going to show an example of a biphasic paratesticular mesothelioma. I have not been able to find any reports of a pure sarcomatoid mesothelioma in this region. I'm sure it can happen. But you should have destructive invasion of the underlying stroma, high-grade nuclear atypia, lots of mitotic activity. This is that example of a biphasic paratesticular mesothelioma. They should be, as you might expect, positive for mesothelial markers. One potential pitfall is that they're sometimes positive for PAX8. So the peritoneum, the mesothelium lining the peritoneum is sometimes PAX8 positive. So you have to be careful because other entities in the differential here are PAX8 positive, like Mullerian tumors and reedy testis tumors. Sometimes you can see loss of BAP1 and MTAP in these tumors. And you can see loss of Merlin because there's NF2 mutations sometimes. You can detect homozygous CDKN2A deletion by FISH in some cases. These behave aggressively. And what are the main diagnostic challenges here? Well, I think one is distinguishing it from the lower grade spectrum of still somewhat scary looking mesothelial tumors. And also because mesotheliomas look a lot like reedy testis adenocarcinomas, and if you're not careful, like a high-grade serous carcinoma. So I think a low power assessment is really helpful here. At low power, we have the surface here, and then we have deep invasion into the underlying stroma that helps us to diagnose this as mesothelioma. We see a extensive papillary architecture, and then a little bit deeper, we've got this irregular infiltration into the underlying tissue, and there's a decent amount of nuclear atypia here as well. One of the larger series that's been published aggregated some mesothelial tumors as well as some serous tumors. What they found, they had 2 cases of mesotheliomas with follow-up. One had lung mets. One biphasic mesothelioma had actually had a previous historical diagnosis of well-differentiated papillary mesothelial tumor at another institution. So something to consider when making that diagnosis. What do these show from a molecular standpoint? As I mentioned, most of the mesotheliomas in this location, well, I should say the most common alteration is NF2 alterations, followed by BAP1 and CDKN2A. And that was also shown in another study where, again, the most common alteration in mesotheliomas was NF2, with less common alterations in CDKN2A and BAP1, and consequently less common loss of expression of those markers immunohistochemically, whereas you don't see those abnormalities in mesotheliomas of uncertain malignant potential, as you might expect. So in the diagnosis of mesothelial tumors, if you're going to diagnose one of the indolent entities, you probably want to use strict criteria. One of the reasons would be in that large Zafar et al. Study, 2 of their mesotheliomas had only focal areas of invasion, and yet they were malignant mesotheliomas. And so this is going to be subject to careful sampling and strict criteria. As I mentioned, IHC results can be misleading, particularly the cases of peritoneal mesothelial tumors that are PAX8 positive. And then just keeping in mind that the molecular alterations you see in paratesticular mesotheliomas may differ from, at least in frequency, from that which you would see in pleural mesotheliomas. All right, quickly moving on to Mullerian epithelial neoplasms. They may be arising from Mullerian remnants like the appendix testis. This looks and stains like tubal epithelium here. Again, in that Zafar et al. Study, they had 15 serous borderline tumors. They established a pretty stable immunophenotype of ER and PAX8 positivity, WT1 positivity. They had follow-up available in 4 patients, in whom there were no adverse events. They had 1 adverse outcome, but that patient had low-grade serous carcinoma. This is an example from a series that we did recently. This is paratesticular serous borderline tumor, but it's histologically identical to one that you would see in the ovary. So we've got broad fibrous cores that are lined by an atypical serous epithelium. We have a hierarchical pattern of branching. So you have progressively smaller branches the farther you go distally. And then if you go to the extreme end of the papilla, then you've got what look like detached tufts of atypical epithelium. And so we put together a series of 19 cases recently. Many of them had this sort of prototypical serous borderline tumor morphology, but we also wanted to highlight experience with some features of serous borderline tumors that are well described in ovarian serous borderline tumors, but have only rarely been described in the paratestis, or some of them never described in the paratestis. For example, micropapillary features like we see in this figure on the right. Another feature that we sometimes saw was microinvasion. This is well established in most studies to not be associated with adverse outcome in the ovary. And here you see characteristic microinvasions. You have little micropapillary structures or sometimes single cells with retraction artifacts and kind of paradoxical maturation that should be over a relatively small volume of the tumor. This is an example of an auto implant, again, common to ovarian serous borderline tumors. This is akin histologically to a desmoplastic non-invasive implant where you have a superficial plaque-like aggregate of epithelium and like granulation tissue stroma. And importantly, in all those sort of less common findings that you see in serous borderline tumors, in our study also, even if you had microinvasion, you had auto implants, the follow-up was no evidence of disease. Or tumors that had microinvasion and micropapillary features, we had no evidence of disease. We had 2 serous carcinomas in here. Unfortunately, there was no follow-up for those. This is one of them. So this had a micropapillary serous borderline tumor. The distinction here is that you have, rather than hierarchical branching, you have these elongated filiform papillae that sort of emanate directly from this broad fibrous or edematous core. It's been described as like a Medusa head appearance. And then in other areas of that same tumor, we had an invasive carcinoma here. We've got really uniform nuclei and a bunch of micropapillary structures that are all fitting together into single retraction spaces with some psammoma bodies. So this is low-grade serous carcinoma. Another case that we had in that series had typical serous borderline tumor, but underlying that, there was this extremely pleomorphic high-grade carcinoma. It had some slit-like glandular spaces, mitotic activity pleomorphism, and this was a high-grade serous carcinoma. And so in summary, serous borderline tumors of the testis and paratestis, at least so far, when you have some of these unusual features, they still should behave in a benign fashion. They can be rarely associated with serous carcinomas, and so that has implications for sampling. They should be positive, as you expect for Pax8 and ER, and they're negative usually for calretin and D240. Why is this difficult? Well, probably because you have to avoid confusing them with more aggressive tumors, both of Mullerian origin, like serous carcinomas, and non-Mullerian tumors, like mesotheliomas and reedy testis adenocarcinomas that can look and stain somewhat similarly. So approaching the end here, just reedy testis neoplasms include both benign and malignant varieties. And a point I wanted to highlight was the certuliform cystadenoma, the reedy testis, was excluded from the recent WHO category of reedy testis neoplasms and was thought to represent intra-reedy growth of Sertoli cell tumors. But one of my co-speakers today did a nice study on benign reedy testis neoplasms, including certuliform cystadenomas. And they showed in that study that with certuliform cystadenomas, you can often identify a transition point from the non-neoplastic reedy testis. They express Pax8 without nuclear expression of beta-catenin, and molecular analysis showed that they were negative for CTNNB1 variants that you would expect in Sertoli cell tumor NOS. And so that points to these not being Sertoli cell tumors. Reedy testis adenocarcinomas, this is a difficult diagnosis to make. They're extremely rare. They're extremely aggressive. They are a diagnosis of exclusion. And so that's going to be the main diagnostic challenge here. And the immunoprofile is going to overlap. Again, recently, Dr. Acosta did a series looking at the molecular underpinnings of reedy testis adenocarcinoma and found alterations in several genes, including genes that are mutated in paratesticular mesothelioma. And then more recently, there was a study that found MET amplification in 2 of 18 cases. And finally, just to wrap up, metastatic tumors. So the most recent and largest series that I'm aware of is 157 metastatic solid tumors to the testis. You can see the most common sites. This is a table from that paper. The most common sites were GU locations, prostate and kidney, followed by colon, rectum, lung, and bladder. But just a few points I wanted to make about that is that even though they were testicular mets, almost half of them involved paratesticular structures as well. So it's relevant to this discussion. The testicular metastasis was the initial presentation of disease in over 10% of those patients. They had no known history of malignancy. What I found really shocking and what I did not expect is that the disease was unilateral in 92% of patients. And in that involved testis, it was presented as a single mass in 93% of the cases. So they're presenting like a primary testicular or paratesticular neoplasm. So the diagnostic challenges here, I think, would be that the patient may not have a history of malignancy, and they're presenting like a primary tumor. So then in summary, I think the differential can usually be resolved with careful attention to morphology, knowing that what you're looking for, and then judiciously applying IHC, maybe molecular adjuncts as well, and then just being aware of the broad spectrum of entities that you can see in this location. And that is it. Thank you.
Thank you, Chris. And that concludes all 3 very informative and educational presentations that we have today. And then I think we have a few questions and to address some questions, a few minutes to address questions from online. And I'll begin with the first question, I guess, to Dr. Baraban. That's a collection of several. Do you grade the neuroendocrine tumors in the testis as what we do in pancreas or GI tract? Is there any criteria that you use, and perhaps any role of Ki67 in this setting?
Sure. So I think we're all familiar with Ki-67 base grading systems for well-differentiated neuroendocrine tumor in the GI tract and the pancreas, where there's a large body of evidence supporting the prognostic role and in some cases helping to decide systemic treatment. Realistically, testicular well-differentiated neuroendocrine tumors are so rare that I'm certainly not aware of a formal prognostic system with cutoffs, et cetera, for like putting these into specific WHO grades. So I'm not aware of a formal grading system, but I think it's reasonable to document in the report the degree of mitotic activity, whether or not there's necrosis, and perhaps make some comment as to if this were a GI tract tumor, it would be graded as such, even though there's perhaps not a formal classification or grading system for these tumors. I think the equally, if not more important thing is to make sure that this is not a component of a post-pubertal type malignant germ cell tumor, and to sample these tumors well, make sure there's not other germ cell tumor components which would have significant implications for management and follow-up.
Thank you very much. I think we have also the question for Dr. Acosta. Do you use 2SC for FH deficiency in Leydig cell tumor? And also any renal cancer that you see in patients with FH deficiency in these patients?
Hi, Dr.
I think
Acosta, I
you are
forgot to
muted.
right. You forgot to unmute yourself, Dr. Acosta.
Can you hear me now?
Yes.
Sorry, so regarding the question of why to restrict the FH assessment to tumors with aggressive histopathologic features, right, or with atypical features, this was a consensus meeting that we had, and we voted on these issues. I was in favor of testing all tumors for FH deficiency, mostly because there are some that we know that don't have any aggressive features. They are very rare, but we know that they don't have any aggressive features and are FH deficient. But the reality is that you would have to test a whole lot of them to get just that one. And the majority of the group thought that that could result in labs that don't have the FH antibody sending out many tumors, and that was probably not justified. My opinion is that if you have FH in your lab, you can test all Leydig cell tumors. These tumors are rare enough that you're not going to go bankrupt if you test all of them for FH. So that's regarding FH. Regarding MDM2 amplification, this is something I didn't mention in the lecture, but the tumors with MDM2 amplification, due to their genomic complexity, because MDM2 amplification tends to present in the context of multiple aneuploidies and genomic instability, those tumors tend to have atypical histopathologic features, and that's, I think, a good reason to just restrict MDM2 testing to those that have atypical features. And the second question is whether there are any other cases where FH deficient testicular tumors also had renal cancers. Well, there was one. Many of these cases are consults, so we have limited history. But there was one patient with a confirmed family history of HLRCC with renal tumors in the father, and the patient himself had cutaneous leiomyomas, but not renal tumors. And for the rest of them, they are mostly consults. I'm not aware of one presenting with a prior renal cancer, but we know that many of them were associated with a germline mutation. Well, some of them.
Thank you, Andy. Perhaps you could also please address, do you use 2SC on FH deficient Leydig cell tumors, or can you please share your experience in this context?
Yeah, thanks for that question. Actually, when we published the first study with Natalie Rizzo, where we made this association between FH deficiency and aggressive features in these tumors, we used 2SC. And I will say that it's quite difficult to interpret mostly because, and if you have used this antibody, you'll see that many cell types have significant background expression in the cytoplasm. So you have to restrict your assessment of a positive tumor to that tumor that has expression in the nucleus. The tumors were positive for 2SC, and when I had the antibody, I used it. I found that all cases that were positive for 2SC were also FH deficient, and I never found the case of Leydig cell tumor that was positive for 2SC expression and had retained expression of FH. So currently I don't have the antibody and I don't send it out for 2SC. But if you have the antibody and you have a good antibody working in your lab, I think it's certainly reasonable to use it.
I think there's still one question for Dr. Baraban regarding the CDX2 staining. Do you order CDX2 for every NETs NET tumors? Or you have a specific criteria for it? Can you answer that question as well?
Sure. So regarding CDX2 expression in testicular well-differentiated neuroendocrine tumors, so I would say that the reason I illustrated that and discussed it is I think it's more a potential pitfall and informs the biology of these tumors more than something that needs to be done for the diagnosis. So for example, if one of these tumors were to metastasize, it's important to know that the testicular neuroendocrine tumor could be CDX2 positive. That doesn't necessarily mean that it's of small bowel origin. It can be useful in the differential diagnosis with some of the other mimickers as sort of a soft feature, but I don't think it's absolutely required. If, for example, you have a clear-cut teratoma and you have a well-differentiated neuroendocrine tumor, you don't absolutely need to perform a CDX2 stain.
Thank you. And then maybe a question for Chris. For the serous tumors that arise from paratestis, do we know if those tumors have RAS-RAF pathway alterations as we see in some of the ovarian counterparts?
Yeah, from what I remember reading, they do, and in a similar proportion to what you would see in the ovary. Yes.
And I have a question for Chris as well, if that's okay, Chris.
Yeah.
So you have immense experience. I know you are like multi-specialty trained in GIN, search bath, in GU, and I think you can handle a lot of different subspecialties. But for someone like perhaps like me, and then perhaps some other people in the audience who do only GU, and if we come across such a paratesticular tumor, would you recommend that we share this with our subspecialty colleagues who are either perhaps pulmonary or perhaps GIN trained, so we can get help from that? Would you recommend that?
I mean, yeah, I do that myself. Like with mesothelial tumors, sometimes I'll get help from people who see more mesothelial tumors than I do. Because I mean, if we're only doing GU, which is what I practice now, we don't see a ton of these tumors, whereas our pulmonary colleagues are seeing a lot more of them. And yeah, I mean, I did practice GYN pathology for a very long time until very recently, so I feel a little more comfortable with like the ovarian ones, but it's still not at all uncommon for me to just run it by someone, because even if you were to show every single paratesticular lesion or tumor that you got over the course of a year, you'd only be showing a few cases, I think. I mean, at least at most institutions. So I think that's totally reasonable, because nobody sees them very often. They're just so rare. So yeah, that's what I would say.
Okay, thank you, Chris. And I have one follow-up question. Like in these patients in these male patients who have these paratesticular Müllerian tumors, is there any thought process or based on your expertise and experience, any connection to possibility of a linkage with endometriosis or like an origin from those, or have you seen any cases, or is there any literature, or could you share your experience, please?
Yeah, so in some of our cases, you could find I didn't see any endometriosis, but I did see areas that I would regard as endosalpingiosis. That's not terribly uncommon. And we even had one case, and I didn't, well, we had one case that looked more like, so when you have a primary peritoneal serous borderline tumor in the GYN world, they can sometimes, they don't exactly look like that hierarchical branching pattern like you see in the ovary. They're more likely to look like what would be regarded as a non-invasive epithelial implant if they were arising in association with an ovarian tumor. So I'm just talking pure primary peritoneal serous borderline tumors. They look a little bit different. And one of our cases actually did look like that. Like it was beyond what we could accept for just endosalpingiosis or something like that. But it does seem to be like a completely analogous, Mullerian pathway. And so, like I said, I haven't personally seen endometriosis, but I have seen endosalpingiosis.
Okay. Jeff and Levi, can I please ask Ezra one question?
Uh,
I have one question for Ezra, if that's okay.
sure.
Yeah. And so Ezra, I just wanted to gauge your thoughts or your recommendations on like how frequently you might recommend I12P testing. Would you do it on all neuroendocrine tumors you would encounter in the testes, or do you have like an algorithm you tend to follow in your diagnostic space?
Yeah, so that's a great question. I would say, first of all, epidemiologically, although these tumors are very rare, it really does seem like the majority of true well-differentiated neuroendocrine tumors that are primary to the testis are related or derived from the prepubertal teratoma pathway. So that's just kind of inform our pretest probability. But certainly in the literature, there are cases reported of carcinoids that are primary to the testis that do have isochrome 12P and presumably are derived from germ cell neoplasia in situ. So we have to, I think, respect that possibility as well. So, kind of like some of what my colleagues are saying, I mean, I think these tumors are so rare that I do think if you encounter one, first thing is make sure the background testis is well represented, because if you find germ cell neoplasia in situ, if you find embryonal carcinoma, et cetera, I don't think there's any utility in doing isochrome 12P FISH, right? We know the nature of that tumor, but if you have a pure carcinoid or a carcinoid where the only other element is a teratoma and it's not an overtly malignant teratoma, I do think it's quite reasonable if you have access to FISH to go ahead and document that. Recognizing, though, the caveat that negative 12P FISH doesn't completely equate to prepubertal type teratoma. Some malignant teratomas, unfortunately, lack that.
Okay, thank you, Ezra. Any other questions, Levi and Jeff, for our speakers?
One more question for Chris. I think you talk about for the mesothelioma or mesothelial lesion in the paratesticular region, BAP1 and then MTAP immunostains might be helpful. I read about that paper, but I forgot. Do you still remember those BAP1 if the mutated or CDKN2A mutated or alteration? Are they mutually exclusive or?
Oh, that's a good question. I don't know that. I don't know the answer to that. I don't know if anybody else does, but that's a good question. I don't know.
Okay. And also you talk about the non-invasive architecture called the complex mesothelioma of some uncertain malignancy. That type, so I agree we have used really strict criteria, right? But so to diagnosis invasive, you really want to see very destructive invasion into the underlying or material, organ or tissue, and also with desmoplastic changes.
Ideally.
Okay. And if we have that non-invasive architecture, but you do BEP1, which is lost, do you still consider it like a malignancy, or is it also malignant?
Yeah, so that's a good question, and I had to present it kind of quickly, but when it's been studied, tumors that were considered either MUMP or this complex mesothelial tumor, whatever you want to call it, the cases that were studied had retained BAP1 and retained MTAP. And then when two other groups looked at Merlin expression, they should ideally have retained Merlin expression because as I had said, like NF2 mutations are more common than the BAP1 and CDKN2A mutations. So I would not make that sort of indolent diagnosis in the face of BAP1 loss. And that's sort of analogous to the sort of concept of mesothelioma in situ. Yeah, so I would not do that. Yeah.
Okay, all right, thank you.
Any other questions, Liwei and Jeff, please? Any other comments from our expert speakers, Chris, Ezra, and Andy, please?
Oh, just thanks for listening. Thanks for inviting.
Yep, thank you. And I do want to share, I think we have some comments in the Q&A tab, and I think which are like kudos for our speakers and for our session organizers, Jeff, Liwei, and our speakers, Chris, Ezra, and Andy. So I'll just share those. And I think some of the kudos which have showed up are, thank you, Ezra, Andres, and Chris, for a very educational session. Thank you for preparing this excellent session. It was very informative and enlightening. Would it be possible to have access to the slides after the session? So for this attendee, I think the answer is that please visit our GUPS website, and this video will be recorded. It is being recorded and should be available hopefully from tomorrow onwards at the GUPS website. Kindly check it out. Then other comments we got were, thank you for your nice, informative presentation and amazing lecture. Thank you. And I personally echo all of these comments from our audience. Like, what a fantastic session. I personally learned so much. It was so educational and so informative. So before we close, I do want to again express my sincere appreciation to our speakers, Ezra, Andy, and Chris, for your time, expertise, I think amazing presentations and such thoughtful contributions to today's discussions. I'm also very thankful to Jeff and Liwei, our session co-organizers and moderators. Thank you to everyone who joined us today. And we look forward to continuing these important conversations in future GUPS events. Thank you again, and have a good day or a good evening. Bye.